Dr. Bijan Saha sir, Dr. Anup Rai sir, uh, for this talk, and I will try my best to explain everything from basic to advanced, because the title of this ventilation is from basic to advanced. So I will share my screen first.
Yeah, you can share.
Is it now visible? Is my screen visible?
Yes, it
Yeah,
is visible.
visible.
Yeah, my PPT is also visible, I think.
I,
Okay. So today my topic is physiology of gas exchange, which is about oxygenation and CO2 removal. This is the first talk series of multiple talks, which will ultimately culminate in the hands-on workshop. Uh, in this workshop, the learning objectives will be pulmonary gas exchange, oxygen and carbon dioxide transport, and effects of ventilator parameters on oxygenation and CO2 removal. What I will not cover is the lung mechanics, because there is a separate presentation by other faculty in next presentation. So I will confine myself to these three physiological aspects of the ventilation. First thing is pulmonary gas exchange. What happens is that the oxygen has to travel from atmosphere to mitochondria. How this happens? We take breathe from atmosphere. From there, oxygen goes inside lung by the way of ventilation, where it goes through nose, upper respiratory tract, lower respiratory tract up to tromboebronchus, and then it goes enters into the alveoli, where gas exchange happens. After gas exchange, oxygen enters into our plasma, where it is transported in two forms. One is bound to hemoglobin, second is dissolved in plasma. And from plasma, it is transported to tissue, where it diffuses into the cells, and where it reaches mitochondria, where high energy phosphate, that is aerobic ATP, is found by aerobic metabolism. So this is the journey of oxygen. Now here three things happen. One is ventilation during inhalation and exhalation. Second is diffusion across multiple membranes at blood-gas barrier in the alveoli as well as in the tissue. And third thing is perfusion, because alveoli and tissue should be perfused for gas exchange to take place. So three things must happen for the oxygen to transfer from one place to another place. Now, before going to the details, one thing I want to ask the participants, they can answer it in chat box. We know that atmospheric pressure is 760 millimeter mercury at sea level. However, this gas is made up of multiple gases. This air is made up of multiple gases. It contains nitrogen, oxygen, carbon dioxide, and other gases in minute amount. The principle is that each gas will exert its own pressure individually. So nitrogen will exert its own pressure, oxygen will exert its own pressure. Carbon dioxide, however, it is in very minute amount in air, so we can say that it exerts almost negligible pressure. Now, air contains 21% FiO2. So, what will be the pressure exerted by oxygen itself in atmosphere? So simply you will multiply 760 with 0.21. What will be the result? What will be the result? Can anyone say when you multiply 760 with FIU, that is 0.21%. Multiply 760 millimeter mercury with 0.21, which is the concentration of oxygen in air. This will give you the partial pressure of oxygen in air. What will be the result? Anyone can say?
So 159.6.
No, no,
One-
no, 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 no.
159, yes, it is 159.6. So partial pressure of oxygen in dry air is 160 millimeter of mercury. So we inspired partial air with a partial pressure of oxygen of 160 millimeter mercury. Now when it reaches alveoli, its partial pressure comes down to 100 millimeter mercury. Now after that, in arteries, partial pressure of oxygen is 90 millimeter of mercury. In capillaries, this is 40 millimeter mercury. In extracellular fluid, 30, and in intracellular fluid, 10 millimeter of mercury. So you can see there is a pressure gradient along with oxygen moves. In alveoli, it is 100 millimeter mercury. In intracellular fluid, it is only 10 millimeter mercury. You also can notice that there is a difference between alveolar partial pressure and arterial partial pressure. Why there is a difference? Later. Now, after this oxygen reaches inside alveoli, after this oxygen reaches inside alveoli, its partial pressure comes down to 100 millimeter mercury. The alveoli are also supplied with blood vessels from here. From one side, pulmonary veins supply blood which are oxygenated, which are deoxygenated with partial pressure of oxygen of 40 millimeter mercury. You remember your blood gases, arterial blood gases or venous blood gases. If you remember your venous blood gas, partial pressure of oxygen in venous blood gas is around 40 and partial pressure of carbon dioxide is around 55 millimeter mercury. Now because alveolar partial pressure of oxygen is 100 millimeter mercury and partial pressure of oxygen in the pulmonary veins is 40 millimeter mercury, the gas has tendency to move from higher partial pressure towards lower partial pressure. Therefore, the oxygen will diffuse from alveolus to pulmonary veins, pulmonary capillaries. And because carbon dioxide pressure is higher in pulmonary veins and in alveolus it is 40 mercury, there is a pressure difference of 5 millimeter mercury, then carbon dioxide will diffuse from pulmonary capillaries towards alveolus. And this diffusion takes place without energy. This diffusion is free without any obstruction because the membranes are highly permeable. And here carbon dioxide permeability is 20 times more than that of CO2. Now, after diffusion, equilibrium takes place. Partial pressure of oxygen also in the pulmonary capillaries also reaches and becomes equal to alveolar partial pressure. Therefore, you can see in the alveolar, in the pulmonary arteries, partial pressure of oxygen is 100 millimeter mercury. In alveolus also, it is 100 millimeter mercury. There should be an equilibrium. Now, in ideal condition, these two pressures should be equal. But in our lungs, there are a few factors because of which this equilibrium is not reached. There is always a difference between alveolar partial pressure of oxygen and pulmonary arterial partial pressure of oxygen. And this difference is usually between 10 to 20 millimeter mercury in newborn. Now, the question is that, is the oxygen being properly transferred from the lungs to the blood? How we can answer this question? That means the lungs, हमारा जो lungs है, the membranes, through the membranes is the oxygen going from alveoli to blood very efficiently. Is there any disease which is preventing this diffusion to occur and oxygen is not getting inside the blood? So for knowing this, we have one parameter that is called alveolar arterial oxygen pressure difference. Here, bigger A means alveolar and smaller A means arterial. You remember alveolar partial pressure of oxygen is always higher than arterial partial pressure of oxygen. So there will be a difference. Now, how we will calculate this difference? Now, again, remember blood gas. In blood gas, you get partial pressure of oxygen, arterial blood gas, which is usually equal to 60 to 100, 60 to 80, 90 millimeter mercury. Now, how will you calculate alveolar partial pressure? If you cannot measure that the partial pressure of alveolar oxygen directly, you have to calculate. However, you measure partial pressure of oxygen in arteries, but directly from blood gas. The what parameters you will need to calculate this partial pressure of oxygen in alveoli? Again, remember, can you please mute your mics?
Dr. Devkumar, Dr. Riya Gupta, please mute your microphone. Dr. Devkumar Mukherjee and Riya Gupta, please mute your microphone.
Mute your microphone.
Yes. Now, what happens? Again, remember my initial slides. To calculate this partial pressure of oxygen in alveoli, you need to know what are the gases which are also exerting partial pressure inside the alveoli. Inside the alveoli, total pressure will be again equal to atmospheric pressure, that is 760 millimeter of mercury. Now, what are the other gases which are there in the alveoli? It is nitrogen, oxygen. Third thing is carbon dioxide, which we have seen here in this slide. Carbon dioxide exerts 40 millimeter mercury partial pressure. And fourth thing is water vapor. From where it came? So your total pressure is equal to atmospheric pressure in the alveoli. Second thing is water vapor. How it came? Because the gas you have inspired traveled through the respiratory tract, and during this traveling, this water gets moist and it gets 100% humidified. At 100% humidity, water vapor itself exerts some pressure and it is equal to 47 millimeter mercury. So you have one parameter atmospheric pressure, you have second parameter water vapor, you have third parameter PCO2. You have PCO2 in the blood from blood gas. In the blood from arterial blood gas, the PCO2. Essentially because all carbon dioxide easily diffuses across the membranes. Therefore, the partial pressure of carbon dioxide in the artery and partial pressure of carbon dioxide in alveolus will be essentially same. Therefore, alveolar carbon dioxide pressure will also be 40 millimeter mercury. So two values, PaO2 and PCO2, you get from blood gas. Now, this PCO2 has to be divided by 0.8 respiratory quotient because of the diet. Now, you can easily calculate, you subtract 47 millimeter mercury from 760, you will get, this is the formula for the calculation of partial pressure oxygen in alveolar gas. You put all the values, you will get the result. Now, anyone calculate and give in the result in 10 seconds. 760 millimeter here, subtract 47 millimeter mercury, this will be 713 millimeter mercury, multiply if the baby is taking room air. Baby is on room air, then FiO2 will be 21%. So you multiply the 713 into mercury with 0.21 and subtract this ratio. So what will be the result? Anyone? It will come around 100 milliliter of mercury. You can calculate. So this is how you calculate alveolar arterial oxygen difference. Now the question is, and usually it is less than 20 milliliter mercury in newborns. In adults, it may be even less. Now, question is why there is alveolar arterial difference. There are two factors. One is right to left shunt, because some of the uh, uh, bronchial arteries originate from aorta directly and supply lung tissues with fresh oxygenated blood. So when it comes out of the lungs, this directly drains into the pulmonary artery without going again into the pulmonary capillaries and getting oxygenated. So some bronchial vessels directly drain into the pulmonary arteries, and because these deoxygenated blood directly mixes with the pulmonary arterial blood, there will be a drop in pulmonary arterial oxygen tension. Second cause is that there is some 2 to 3% of cardiac output goes into right to left shunt. That means whatever cardiac output goes through pulmonary arteries to the pulmonary circulation, some of that circulation is wasted. This blood does not take part in gas exchange. Therefore, this again bypasses the pulmonary circulation, pulmonary gas exchange, and mixes directly into the pulmonary arteries. Therefore, there is a difference between pulmonary arterial oxygen tension and pulmonary alveolar oxygen tension. And alveolar oxygen tension will always be higher than pulmonary arterial oxygen tension. Now, with this background, we can categorize the causes of hypoxemia and hypercapnia into 5 major categories. One is low inspired partial pressure of oxygen. Second is hypoventilation. Third is ventilation perfusion inequality. Fourth is shunting. These third and fourth causes combined called ventilation perfusion mismatch, and fifth causes diffusion limitation. Now, what is low inspired oxygen? This is a real world scenario where we go up above sea level. Suppose we are climbing the mountain, or we are transporting a patient by air at 8,000 or 10,000 feet above sea level. What will be the atmospheric pressure at 10,000 feet above sea level? Will it be 760 millimeter mercury, or it will be lower? It will be lower. As we go high, the atmospheric pressure comes down. Therefore, at 8,000, 10,000 feet above sea level, it might be 600 millimeter mercury. However, the FiO2 is not low. Just focus that oxygen concentration at height is not low. It is partial pressure of oxygen is low because total atmospheric pressure is low. Now again, you can calculate partial pressure of oxygen at 8,000 feet, where at total atmospheric pressure is only 600 mercury, and FiO2 is again 21%. So multiply 600 into by 0.21, you will get around 125 millimeter of mercury of partial pressure of oxygen. So now at height, it is due to the low atmospheric pressure. Because of this, there is low oxygen tension inside alveoli. At sea level, inside alveoli, partial pressure of oxygen is 160 millimeter mercury. At height, partial pressure of oxygen is only 120 millimeter mercury. That will cause hypoxemia. So, if you are transporting a patient who has a requirement of FiO2 of 21% at sea level at the height of 8,000 10,000 feet above sea level, it will require much higher FiO2 to maintain that same level of alveolar partial pressure of oxygen. I think everyone has understood. So how will you calculate the requirement of FiO2 at higher level? This requirement is given by this formula. FiO2 into barometric pressure at sea level divided by barometric pressure at height. This question was asked in my DM entrance examination. So I mentioned it. So you always remember FiO2 or oxygen concentration is not low at height. It is the total pressure and partial pressure of oxygen which is low, which causes hypoxemia. Second cause is hypoventilation. Now, if a baby is sedated or even if the baby is on ventilator and it is hypoventilating, what will be the effect of hypoventilation on the oxygenation and carbon dioxide? Actually, because there is hypoventilation, a smaller amount of air is going inside the alveoli. Therefore, a smaller amount of oxygen is going inside alveoli. There is smaller amount of exchange happening in the alveoli. Therefore, what happens? Your PaO2 will come down. There is a critical value below which, if alveolar ventilation come down, the PaO2, that means alveolar partial pressure of oxygen, will precipitously come down. That will again cause severe hypoxemia very rapidly. At the same time, hypoventilation also causes rise in PaCO2 level rapidly. So in hypoventilation, both PaO2 level will go down and PaCO2 level will go down. Now, what will be the effect on alveolar arterial oxygen difference? Will it be altered? No, because as the PaO2 will go down, partial pressure of oxygen in the blood will also go down. Both will go down simultaneously. Both will go down simultaneously. Therefore, alveolar arterial pressure difference will not be there in hypoventilation. Also, in case of low PaO2 level, alveolar oxygen pressure difference will not be found. Now, third type of hypoxemia is due to ventilation perfusion inequality. That means low ventilation perfusion. Now, this is a model of two alveoli. You see, both the alveoli are well perfused. However, one alveolus is well ventilated, second alveolus is poorly ventilated. Although some ventilation is happening here, because less amount of air, that is less amount of oxygen is going inside this alveolus, the PaO2 in the alveolus is low. However, in this normal alveolus, PaO2 is normal. And now you see that in normal alveolus, ventilation is good, perfusion is good. Therefore, ventilation perfusion ratio is normal. Here, ventilation is poor, although perfusion is normal. Therefore, ventilation perfusion ratio is low. What will be the effect? Because the only this well ventilated, when perfused alveolus is taking part efficiently in gas exchange. Here, the gas exchange will be hampered. PaO2 will not go inside arteries, and PCO2 will also not come out of the artery into the alveoli. This graph shows the relationship between ventilation perfusion ratio and PO2 and PCO2. Now, you see here, when ventilation perfusion ratio is high or good, PO2 will rise. That means alveolar pressure will rise. Therefore, arterial oxygenation will also rise. However, there is a value below which, if ventilation perfusion ratio comes down, again PO2 value will drastically go down. At the same time, PaCO2 value will also slightly go up. However, because of hypoxemia, there is hyperventilation. Then the PaCO2 the value, which was initially higher, will come down or normalize. So, with a lower ventilation perfusion ratio also, the alveolar partial pressure oxygen will come down. Now, what will be the effect on alveolar partial pressure and difference between alveolar partial pressure and arterial partial pressure in this case? Can anyone guess? So we will see later. Now, there is another situation where ventilation perfusion ratio is very high. Again, there is two alveoli. One alveolus is well ventilated as well as well perfused. Therefore, PaO2 is normal, PCO2 is normal, and gas exchange is occurring very efficiently in this alveolus. Now, what is happening in this alveolus? There is no perfusion. There is no blood supply to this alveolus. Although this alveolus is ventilating well, still ventilation is zero, ventilation is high, perfusion is zero. So the ratio will be infinity. So this is a case of anatomical dead space. The fourth type of hypoxemia occurs due to shunt. Here, what is happening? Both alveoli are well perfused. Perfusion is good. One alveolus is well ventilated. Ventilation perfusion ratio is normal. PaO2 is normal. PCO2 is normal. However, one alveolus is completely blocked. There is no air exchange in the alveolus. What is the clinical scenario where it happens? It is due to intrapulmonary shunt. This is called intrapulmonary shunt. Now, ventilation is zero, perfusion is okay, the ratio will be zero. So, in shunt, ventilation perfusion will be zero. This happens in many other cases. Ventilation perfusion mismatch occurs in many cases of lung pathologies like RDS, meconium aspiration syndrome, pneumonia. In any lung pathology, the main cause of hypoxemia is ventilation perfusion mismatch. And this shunt is an extreme of case of ventilation perfusion inequality. Another cause of shunt is intracardiac lythotriection to right to left intracardiac pathologies, congenital anomalies. Now, in this case, even if you increase FiO2, it will not respond to your SpO2, FiO2 increase, and SpO2 will not increase. Second thing, PCO2 will also increase because there is no ventilation. And carbon dioxide has no way to come out of the pulmonary arteries and go inside the alveoli. So PCO2 will also increase, although it may be compensated by hyperventilation. If this shunt is 40 to 50% of the cardiac output, the part there is at least 10 milliliter of mercury increase in PCO2 level. A fifth cause of hypoxemia is diffusion limitation. We know that carbon dioxide and oxygen diffuses freely across this membrane. This membrane consists of the alveolar lining and surfactant, the cells, the basement membrane, the interstitial tissue, again the basement membrane of the arteries, capillaries, the endothelium, the plasma, and RBC membrane, and then it goes inside the hemoglobin, inside to bind to the hemoglobin. Now this diffusion depends on the size of the or the molecular weight of the gas itself, the thickness of the blood-brain barrier. If there is interstitial edema, the interstitial space will thicken and there will be increased distance between the alveolar surface and the plasma. Third is the surface area for the pulmonary gas exchange. Suppose we have seen two scenarios: ventilation, perfusion, inequality, and shunt. If the alveoli are collapsed or distended without perfusion, the ventilation perfusion mismatch is high, the total surface area of the lung available for gas exchange will be low. Again, there will be diffusion limitation. Fourth is hemoglobin gas binding capacity. Now again, if hemoglobin amount is less in this RBC, less amount of oxygen will bind to the hemoglobin. Therefore, diffusion will not take place. And fifth is capillary transit time. Let's see what is this. In alveoli, suppose this is one alveolus. Here, this end is pulmonary arterial end. This is the alveolar capillary, and the right side is pulmonary venous end. From pulmonary artery, this deoxygenated blood comes and enters into the pulmonary capillaries. The PaO2 is 40 millimeter mercury. In alveoli, PaO2 is 100 millimeter mercury. So oxygen will diffuse from alveoli into the pulmonary capillaries. Now, this blood or RBC takes around 0.75 seconds to travel from one end of the capillary, pulmonary arterial end of the capillary, to the venous end of the capillary. And diffusion takes place only during first 0.25 second of the transit time. That means during first 0.25 second of the transit time, the equilibrium will take place, will happen, and alveolar capillary oxygen pressure will equalize with that of the alveolar pressure, and it happens only within first 0.25 seconds. So it has reserve of 3 times reserve for diffusion equilibrium to take place. Now, in what conditions this capillary transit time will come down? So, there are a few conditions mainly related to adults. One, like vigorous exercise at sea level. Even at high altitude, anyone if exercises vigorously, capillary transit time will become low because cardiac output will be high, heart rate will be high, the blood flow will be higher. Sorry. Third thing is pulmonary edema. Diffusion capacity, pulmonary edema in which interstitial fluid is accumulated, the diffusion of oxygen will not take place. Fourth example is pulmonary fibrosis, or in newborn bronchopulmonary dysplasia, where most of the lung is fibrous. Other causes may be, as I have told you shunt and dead space, that is ventilation perfusion mismatch and anemia. Now, in nutshell, what I have explained in multiple slides, now I will summarize it in one slide. There are 4 types of alveoli. One is well perfused and well ventilated. Second type of alveoli are well ventilated, however perfusion is poor. So this is anatomical dead space. Third type of alveoli are having thick walls because of secretions as well as the interstitial edema. It is mainly interstitial edema which results in low diffusion. That is diffusion barrier. And 4 type of alveoli are those alveoli in which blood supply is good, but there is no ventilation because of secretions, debris, which happens in many of the lung conditions like pneumonia or any other thing. Pneumonia or RDS. In RDS, alveoli are completely collapsed, so there is no ventilation, although perfusion will be there. So these are the 4 types of alveoli which are the causes of the pathology and hypoxemia in the diseases. And most common cause of hypoxemia is mainly ventilation perfusion mismatch in the lungs. Now, why we want to know about alveolar oxygen partial pressure difference? In all other conditions, FiO2 increase will improve SpO2, but in shunt, it will not improve SpO2. This is the characteristic of shunt. In hypoventilation, decrease PiO2, PO2 difference will be normal, but in all other conditions, like in diffusion limitation, because alveolar gas is not diffusing into the pulmonary arteries, there will be increase in this difference. Low ventilation perfusion cases or shunt, alveolar oxygen is not getting diffused into the pulmonary arteries. There again will be increase in this difference. So this alveolar arterial oxygen pressure, partial pressure difference will help you in identify the underlying cause of low oxygen tension due to pulmonary causes. Now we have talked about dead space. What is dead space? It is the fraction of tidal volume which does not participate in gas exchange. There are 3 types of dead spaces. One is due to the apparatus itself. When you ventilate a baby, you put an ET tube and put the baby on ventilator. The circuit, the flow sensor, everything contributes to the dead space and does not take part in any gas exchange. In newborn, the flow sensor volume is always less than 1 ml. You might be knowing what is flow sensor in ventilator. In adults or in children, what we use is for humidification, we use HME filter, which has a very high dead space, 20 to 25 ml dead space. However, in newborn, what is the tidal volume? It is only 4 to 6 ml per kg. If it is a 2 kg baby, the total tidal volume will be only maximum of 12 ml per kg. And if you apply or put a HME filter in the inspiratory of the ventilator, no tidal volume must be taken into account when you are ventilating the baby. Like use the flow sensor, which has less than 1 ml of dead space, and specific for the neonate. Cut the ET tube for appropriate size so that dead space here also will get small. Second dead space is anatomical dead space, which is the trachea, bronchi, bronchioles up to the terminal bronchioles. Here also oxygen does not take part in gas exchange. After that, there is alveolar dead space, which we have described. That is, alveolar dead space means ventilation is occurring, but there is no perfusion. That is, ventilation perfusion ratio is 0. Now, around if you calculate the percentage of dead space to tidal volume, it will be around 30%, 25 to 30%. And if there is high dead space, both PO2 will be low and PCO2 will be high. Therefore, you will have to reduce dead space. Or a pressure dead space, I have told you, cut the ET2, use smaller flow sensor, and for anatomical dead space, you cannot do much, but for alveolar dead space, how will you reduce this dead space? We will talk about it later. Now, there is another thing, the effect of gravity on oxygenation and lung perfusion and oxygenation. Why it is important? Because our neurons lie supine and adults usually remain upright. First, we will discuss what is the application of this knowledge. When we stand upright, this is lung in vertical position. Lung can be divided into 3 zones. Why? Actually, in 1960s, a researcher named West has given this categorization about zones of the lungs. The lower zones of the lungs, in the middle of the zone of the lung and in the upper zone of the lung, there is some difference. There are 2 things. One is lung tissue itself. Second is pulmonary vessels. Now focus on pulmonary vessels, and second, lung tissue, that means alveoli. The lower part of the lung, what happens? Because of the gravity, the fluid inside the pulmonary vessels exert more pressure. Now, कोई भी लिक्विड होता है उसमें ग्रेविटी काम करती है, बट क्या गैस में ग्रेविटी काम करती है? गैस पर ग्रेविटी काम नहीं करती है, और फ्लूइड में ग्रेविटी काम करती है. So, in the lower part of the lung, the fluid has more pressure, therefore it keeps the pulmonary arteries and pulmonary veins open. However, alveoli are always open in all 3 zones. Here also alveoli are open. However, the pressure inside pulmonary arteries and veins are high, so it remains open and overcome the alveolar pressure. What is happening here? Alveolar pressure is same as in the lower zone or as in the upper zone. However, because it is somewhat above this artery, so pulmonary arterial pressure here will be lower, pulmonary venous pressure here will be lower, therefore it will get compressed, and therefore there will be low perfusion. In the upper zone, alveolar pressure again remains same, but because due to gravity, the pulmonary arterial pressure and pulmonary venous pressure is even lower, therefore it becomes totally collapsed, obstructed or constricted. What is happening here?
Just 1 minute. Prashanjita, please mute your mic. Prashanjita, please mute your mic. Prashanjita, please mute your mic. So now start.
Okay, so what is happening here? Ventilation is good, perfusion is good in the lower zone. Here ventilation is good, but perfusion is little bit low. Or here ventilation is good, but there is no perfusion. This is the effect of gravity on pulmonary perfusion. Now, what is happening to the lung tissues? This is a model. Suppose you imagine lung tissue here in place of this spring. Spring is kept vertical. What is happening? Because of the gravity, the spring is pulling down. So more rings are there at the lower part of the spring. Less rings are there at the upper part of spring. The same thing happens with the lung tissues. Because of the weight of the lung tissue itself, the lower part of the lung tissues are more dense, upper part of lung tissues are less dense. Then what will happen to the alveoli? In the lower part of the alveoli, lower part of the lungs, the alveoli will be smaller, and the upper part of the alveoli, the lungs alveoli will be larger. Now, if this is one cause of difference in the ventilation. Second cause is intrapulmonary pressure. Because of gravity, the lung is pulled down. Therefore, in the upper part of the intrapleural space, the intrapleural pressure is high. In the lower part of this intrapleural space, the intrapleural pressure is lower. Then what is happening? Again, there is less transpleural pressure here in the lower part. There is more transpleural pressure in the upper part. Less transpleural pressure means alveoli are less stressed. More transpleural pressure means alveoli are more open. So what is happening? Again, notice if alveoli are small, it has more space to distend, more capacity to distend. ये वाला एल्वियोलस ऑलरेडी ओपन है, तो ये कितना खुलेगा अगर आप प्रेशर ज्यादा देंगे? ऊपर वाला एल्वियोलस, ये वाला एल्वियोलस छोटा है, इसको प्रेशर देंगे तो ज्यादा खुलेगा. तो वेयर इज द कंप्लायंस? In the lower part of the lungs, alveoli have more compliance. It will ventilate well. In the upper part of the lung, alveoli have less compliance, and on giving pressure or PIP, it will stretch less. So ventilation will be more in the dependent part, less in the non-dependent part. Now, so this is the same thing. And this happens in any body position, in upright, supine, lateral, and prone. But it is applicable in adults, mainly in adults. In newborn, it is said that the thing is reversed. That is, non-dependent part of the lungs are more ventilated. Dependent parts of the lungs are less ventilated. What is the application? Usually in prone position, the babies improve oxygenation as well as ventilation. So usually when we ventilate the baby, either we put on them on CPAP or invasive ventilation. When the oxygenation and ventilation is not happening well, even on higher setting, we keep the baby on prone position so that oxygenation and ventilation improves. Because in prone position, upper part will also be equally ventilated. Now, gas exchange has happened in the pulmonary surface. There, oxygen has come into the plasma. Now, oxygen has to go to the tissues. How it
I'm sure you are mute. Unmute karo. Please unmute yourself.
Dr. Prasad, please unmute.
Ramesh sir, please unmute yourself.
I think he has some problem with connection.
I think till Rameshwar gets connected, let me tell you the question I was telling. Oxygen kinetics. That means oxygen from the alveoli has to travel to the tissues. So how the oxygen is flown?
Okay, I am. Okay, sir. Can you hear
Yes.
me
No, yes. Now you continue.
now? Now let's look at the journey of oxygen from lungs to the tissues. There is an analogy in our day-to-day life. जैसे कि आप समझिए एक ट्रक है, ट्रक भर गया, ऑक्सीजन से लोड हो गया आपका लंग्स में। अब ऑक्सीजन को लोड होने के लिए ट्रक चाहिए, और एक ट्रक में कितना ऑक्सीजन आएगा, दैट विल बी ऑक्सीजन कंटेंट ऑफ द ब्लड. नाउ ट्रक हैज टू ट्रैवल from the lungs to the tissue. So who will drive the truck? How this truck will go to reach to at the tissue level? So it is the heart which will pump the blood towards the tissue. And third thing, ट्रक तो पहुंच गया आपका टिश्यू के पास ऑक्सीजन लेके. Now it has to unload the oxygen to the tissue. So there are 3 steps. One is loading, how it will be loaded, and how much oxygen will be loaded in blood. Second, how this oxygen from uh, uh, pulmonary end will travel to the tissue, and how much oxygen will be delivered to the tissue or taken up by the tissue. Now, how the oxygen is transported? Oxygen is transported in 2 forms. One is oxygen bound to hemoglobin. Second is oxygen dissolved in plasma. 98% of oxygen is bound to hemoglobin and transported as such with the plasma. And this saturation percentage of hemoglobin is detected by your pulse oximeter. Therefore, you remember, whatever you see in pulse oximeter is the percentage saturation of hemoglobin. Only 2% of oxygen is dissolved in plasma and transported as such in plasma. And this dissolved oxygen is measured by PaO2, which is measured by blood gas. Now, there is another value in your blood gas, arterial blood gas. You remember your arterial blood gas, here there is a value called SaO2, saturation of arterial oxygen. It is the ratio of oxyhemoglobin divided by total hemoglobin. However, in blood gas, they calculate something else. This actual SO2 is measured by co-oximeter, pulse co-oximeter. This is another device. This measures all 4 types of hemoglobin: oxyhemoglobin, deoxyhemoglobin, methemoglobin, and carboxyhemoglobin. And this total hemoglobin is the denominator in SaO2. This is also important when you are evaluating a baby with hypoxemia. Why it is important? If suppose there is high level of methemoglobin or high level of carboxyhemoglobin, which happens in carbon monoxide poisoning, or in if you use INO, these 2 types of hemoglobin are not present in the denominator when you calculate SpO2. Therefore, your SpO2 will be normal. However, SaO2, which you measure in pulse co-oximetry, will be lower, and PaO2 will also be lower because PaO2 is directly proportional to SaO2. So it will be detected by this. So you must remember what you are monitoring, what is being monitored by pulse oximeter, what you are measuring in your blood gas. Now, this is how oxygen is transported. Now, how much oxygen is transported by each ml or each decimil of blood. This is called oxygen content of the blood. How it is calculated? This is the combination of total of oxygen bound to hemoglobin and oxygen dissolved in plasma. Each gram of hemoglobin is bound to 1.34 ml of oxygen. And each 100 ml of blood contains 0.03 ml of oxygen per millimeter of mercury. Now, oxygen content of the blood will be the addition of these two types of oxygen. Now, you solve the formula, calculate the formula yourself, and tell me the result. What will be your uh, arterial oxygen
CO2.
content? Hemoglobin is, suppose it is 50 gram per deciliter. SOO2 in arterial oxygen, it is 98% or 100%. PO2 is 100 millimeter mercury. So take this value and calculate CO2 and give me the answer. Any one participant can calculate and give me the answer. 10 seconds and give me the answer. Anyone?
Given
10
is
seconds.
70.
Hmm?
It will not be 70, it will be less.
How much?
Arnav has written 70, it will not be 70, it will be less than 20, it will be 20.
I didn't hear. So suppose hemoglobin is 15 gram per deciliter. SaO2 is in arterial. SaO2 is always 98%, 100% of PO2 is 100. So if you solve this equation, it is how much?
I think
It, it will be around 20 ml per deciliter.
yeah.
Has anyone calculated this and arrived at this result?
Most of them have calculated, some of them are tried.
Okay.
Some
So
19.71, 19.70, 18. I think they are those who are close to 20, they are correct.
yeah. So now you can change the hemoglobin level because in newborn hemoglobin level is usually 18 gram per deciliter, 17 gram per deciliter. So you can change hemoglobin level. You can also see what is the result. Now similarly, you can also calculate the venous oxygen content with the same formula. Here PVO2 will be, you remember your venous blood gas PVO2 level. What is the venous blood gas O2 level? It is around 40 millimeter mercury again. At 40 millimeter mercury, saturation of hemoglobin is around 75%. So again, for same hemoglobin level, 15 gram per deciliter, yes, hemoglobin saturation of 75% and partial phase of oxygen is venous blood of 40 millimeter mercury. You calculate the content, oxygen content in venous blood, and keep it because it will be used for the calculation of another value. Now, here is the oxygen binding, oxygen hemoglobin dissociation curve. So, because 98% of oxygen is bound to hemoglobin and is transported bound to hemoglobin, we must understand what is oxygen hemoglobin dissociation curve. Now, I want you to focus around three PaO2 values. One value is this one. Now, at horizontal line is PaO2 value. Vertical line is your percentage of hemoglobin saturation, which you pulse in pulse oximeter, you get as SpO2. In blood gas, you get it as SaO2. Now, in pulse oximeter, if your SpO2 is 50%, what will be your PO2 value? If it is 50%, your PaO2 value will be usually around 26 millimeter of mercury, and it is called P50 of hemoglobin. That means the PaO2 value at which hemoglobin is 50% saturated is called P50 value of the hemoglobin, and in adult it is 26 millimeter mercury, and in fetus it is 20 millimeter of mercury. That means in fetus this oxygen hemoglobin dissociation curve will be because I will draw one vertical line from here, so oxygen hemoglobin dissociation curve will be shifted towards left side. So this shows. Now what does this mean? As the partial pressure of oxygen increases, the saturation of hemoglobin increases. At the partial pressure of oxygen increases, the saturation of hemoglobin increases. However, its shape is S-shaped. At this middle part of the graph, the oxygen HbO2 hemoglobin saturation increases rapidly. But however, after some time, it becomes more horizontal. Now, I want you to focus on the second part. Now, when HbO2 percentage, SpO2 reaches 90%, what is the corresponding PaO2 value? It is around 60 to 65 millimeter mercury. That means when you are seeing that your pulse oximeter value is 90% or above, the PaO2 value in blood has already reached above 60 millimeter mercury. Have you understood? And normal PaO2 value in the blood is 50 to 80 millimeter mercury. Now, after this, you see what is happening. Before this, you see what is happening. If PaO2 value goes below this 55 or 60 millimeter mercury, the hemoglobin saturation falls rapidly. If it goes, PaO2 values goes above this 60 millimeter mercury, however, the hemoglobin saturation does not increase much. That means if you already your baby is already having hemoglobin saturation of or SpO2 of 95%, further increase in FiO2 will not increase your SpO2 much, but it will only increase the partial pressure of oxygen. I will come to this again later. Third point I want you to notice is this value. What is the partial pressure of oxygen in venous blood? It is 40 millimeter mercury. You draw a vertical line and corresponding SaO2 or SbO2 value. It is around 75%, which I told you to take for the calculation of oxygen content in the venous blood. So for a partial pressure of oxygen 40 millimeter mercury, saturation of hemoglobin will be 75%. So these are the three things which you should remember. Therefore, you should not hyperoxygenate the baby if your baby's SpO2 is already above 90%, because there will be no incremental benefit of adding oxygen in for this baby. Now, what are the things which will affect this graph? Some factors will shift the graph towards left side. That means there will be less dissociation, more oxygen will be retained by the hemoglobin. And some factors like acidemia, high temperature, increased CO2, increased 2,3-DPG, these are the things when baby goes into shock or become more sick, where your graph will shift towards right side. Therefore, hemoglobin will easily give away its oxygen to the tissue, because tissue will need more oxygen at lower pressure. This is all about hemoglobin oxygen dissociation curve. Now, third thing is oxygen delivery to the tissue. Now, oxygen is loaded in the plasma, but it has to go to the tissue. The amount which will go to the tissue will be calculated by cardiac output into oxygen content of the arteries. Cardiac output in newborn is around 150 ml per kg per minute, and CO2 have calculated around 20-22 ml. You will just multiply these two things, you will get the oxygen delivered, amount of oxygen delivered to the tissue in each ml of the blood. Now, fourth thing is that now oxygen has reached to the tissue, whether it has been unloaded or not, or how much it is unloaded at tissue level. ट्रक तो सामान लेके या ऑक्सीजन लेके टिश्यू तक पहुंच गया, क्या ट्रक से अनलोडिंग हुआ, और अनलोडिंग हुआ तो कितना अनलोड हुआ? So, 100 मिलीमीटर मरकरी ट्रक से लोड हुआ था पॉलमरी एरिया में, उसमें 25 ml निकला. तो this is called oxygen extraction or oxygen consumption. It is in normal, in newborn, it is usually 6 to 8 ml per kg per minute. You can easily calculate, you might have calculated CO2 and CVO2. Now just deduct these two values from each other. You will get the value. It will be around 5 ml. Now oxygen extraction ratio, it will be the ratio of oxygen delivered by total oxygen extracted by total oxygen delivered. So usually it is 25 to 30%. That means the oxygen, 25 to 30% of oxygen is extracted by the tissue. And simply, if you want to take advantage of your blood gas, if you solve this formula, then you will get this formula finally, where you will only need SaO2, SbO2 to calculate oxygen extraction percentage. Now, this oxygen extraction at tissue level, that means unloading of oxygen at tissue level from hemoglobin, will also be affected by multiple factors. One is oxygen gradient, second is tissue blood flow, and third is hemoglobin oxygen affinity. If oxygen gradient is low, oxygen extraction will be low. Oxygen gradient is high, oxygen extraction will be high. Tissue blood flow is low, like in shock, oxygen extraction will be low. Hemoglobin oxygen affinity, like in fetal hemoglobin, if fetal hemoglobin is high, the tissue extraction will be low. Now again, what will be the utility of knowing this in clinical practice? Suppose a baby is having hypoxia. How do you intervene? How do you correct hypoxemia in a baby? Now, you will increase oxygen content of the plasma. You will increase oxygen content of the plasma by increasing FiO2 or putting the baby on ventilator, which will increase oxygen content of the plasma, or you will increase cardiac output so that more blood will go to the tissues. So these two things you intervene. You increase the oxygen content by increasing FiO2 or putting the baby on ventilator. You increase cardiac output by improving the blood flow by adding inotropes or giving boluses. So what you are doing here? You are increasing the delivery of the oxygen at tissue level. You are trying to increase the delivery of oxygen at tissue level. My question is whether you are affecting the oxygen extraction of the at tissue level? No, usually we do not have anything, any intervention practically, except by modifying these things, oxygen content, cardiac output. We do not have practically any intervention here by which we can increase the oxygen extraction or of the tissue directly. Here also for oxygen content of the tissue for the artery, you have another thing, that is hemoglobin. You also transfuse the baby so that it will improve the delivery of oxygen to the tissue. Therefore, in clinical practice, we are targeting delivery of oxygen to the tissues. Background knowledge of arterial oxygen content and other things, we will revisit this hemoglobin oxygen dissociation curve. Now again, the horizontal line depicts the partial pressure of oxygen in arteries. This is the hemoglobin saturation. Now we have seen at around 60 millimeter mercury, the oxygen hemoglobin dissociation curve starts becoming horizontal. Now see at CO2 of 100 millimeter mercury. The pulse oximeter value will again give you the digit of 100% SpO2. Now, if you keep increasing PO2 value by increasing FiO2, you are increasing FiO2, you are increasing PO2 value. The PO2 value will increase by the way of increase in alveolar oxygen tension. It may reach up to 600, 700 millimeter mercury because it can replace all of the nitrogen at 100% FiO2 because you know the partial pressure of oxygen depends on the concentration. However, what will be the effect of oxygen content of the plasma of the arterial blood? There is virtually very little increment in the oxygen content of the plasma from 20 to 22 millimeter mercury. Only 2 ml per deciliter increase in oxygen content of the plasma will be there. So virtually after 100 millimeter mercury of PO2, there is no meaning of increasing FiO2, keeping PO2 above 100 millimeter mercury because the yield will be very low. And ultimately it will cause oxygen toxicity and many other problems. So we must avoid oxygen toxicity because oxygen is a drug. We have to rationally use oxygen. Now there is another concept. We have seen oxygen delivery, understood about oxygen delivery and oxygen consumption. There is a relationship between oxygen delivery and oxygen consumption. What happens when oxygen delivery is good? Here there is zero oxygen delivery, or here there is high oxygen delivery. Here there is zero oxygen consumption. As we go up in the y-axis, there is high oxygen consumption. When oxygen delivery is good, oxygen consumption will be good and will be almost static. But when oxygen delivery comes down, at some critical point where oxygen delivery is very low, the oxygen consumption will also start decreasing and it will precipitously decrease. Therefore, you will have to maintain a critical oxygen delivery level so that it does not reach this critical point where oxygen consumption starts going down. This is also important.
I'm not sure.
Yeah. Yes.
We need to give some time to the audience. or question answer.
Okay. Anything you want to ask till now, whatever you didn't understood. One more point is that when oxygen delivery is going down, oxygen extraction will increase. So it will compensate the decrease in oxygen delivery. Is there anything which you do not understand, which has gone above your head or something else?
Our fitness slide है.
Not much. 7-8 slides, perhaps.
We have to keep their concentration.
Okay.
Continue.
So, about carbon dioxide transport, there is not much to say. There are three ways carbon dioxide is transported. One is bicarbonate, second is carbon hemoglobin, third is dissolved carbon dioxide. The maximum carbon dioxide is transported by the way of bicarbonate 70 to 90%, 10 to 20%, and 10%. The actual goal of ventilation. Now come to the clinical part. What is the actual goal of ventilation? It is oxygenation that improves PO2, and it is ventilation which reduces PCO2. This is in nutshell, which I have already described. I think I will leave it to the audience. Now, how oxygenation will be improved when baby is ventilated? There are three ways. One is MAP, mean airway pressure. Second is FiO2. Third is pulmonary blood flow. Now, MAP directly affects functional reservoir capacity. So, you have seen what are the causes of hypoxia. More common causes: ventilation perfusion mismatch. If you distend alveoli by giving MAP or PEEP, then it will open up the collapsed alveoli, it will improve ventilation perfusion matching, and it will ultimately improve the oxygenation. What are the factors which improves MAP, which increases that? The most important factor is PWP, because most of the IE ratio is 1:2. So during respiratory cycle, most of the time the baby is in expiratory phase. So the maximum effect will be when you increase the P, then MAP will directly increase. Second is FiO2, and third is pulmonary blood flow. When the pulmonary blood flow is compromised, one is shunt, second is pulmonary arterial hypertension or pulmonary hypertension of the newborn, where pulmonary blood flow is not there to the lungs, and it will also not respond to the to hypoxemia. And in one index which is important for oxygenation is oxygenation index. This is the product of your input value, that is MAP and FiO2, on which oxygenation depends, and your output value, that is PO2, for which you give these two things. Now, how pulmonary vascular resistance or pulmonary flow, blood flow, affects the oxygenation. If lungs are not distended well, so in the initial part of in the collapsed lungs, pulmonary vascular resistance is high. In over distended lung also, pulmonary vascular resistance will be high. Only in the optimally ventilated lungs, optimally distended lungs, pulmonary vascular resistance will be minimum. And this is at FRC, functional residual capacity. Therefore, your attempt should always be to keep the alveoli open at functional residual capacity. What are the causes of increasing pulmonary vascular? It is lung volume, as it is depicted in this graph. Second is hypoxic pulmonary vasoconstriction. Hypoxia is a potent pulmonary vasoconstrictor, and cutoff value at below 50 millimeter or 60 millimeter of mercury, pulmonary vasoconstriction starts. Other causes are metabolic or endocrine, like if you use alpha agonist for the management of shock, or beta agonist for the management of shock. One will constrict or one will dilate. High hematocrit like polycythemia. These things will increase pulmonary vascularization. How will you, therefore, to improve oxygenation, we will always adjust MAP first. Inadequate MAP will cause surfactant inactivation, decreased lung compliance. It will cause atelectotrauma. Because of repeated opening and closing of alveoli, it will reduce blood of increase blood work of breathing. Excessive MAP will decrease lung again, will cause air leak. At higher MAP, there will be little change in tidal volume with higher increase in PIP, and it will also decrease venous return and will cause shock. Now, how will you improve carbon dioxide removal? How will you treat hypercarbia? It will totally depend on minute ventilation, and minute ventilation depends on tidal volume and respiratory rate. And respiratory rate will again depend on TI and T, and tidal volume will depend on delta P, that is P minus PIP. So your target should be minute ventilation if your problem is removal of carbon dioxide. And delta P and tidal volume again depends on time constant, which depends on compliance and resistance. And these all things are the parts of lung mechanics, which will be covered in the next talk. Therefore, I will not go into the details. These are the normal parameters, lung parameters in the newborn.
I think
So,
this can be discussed in the next class. These are all lungs.
yes. So, in my final slide, my take-home message is mechanical ventilation affect alveolar gas exchange, that is both hypoxemia and hypocapnia. Prone ventilation improve ventilation perfusion matching. Oxygen delivery does not guarantee oxygen utilization and treat the cause of hypoxemia and hypercarbia. Thank you.
Thank you, Ramesh sir, for the excellent presentation. Nice, actually describing the physiology of gas flow. I think what Ramesh sir has said, let me summarize. First of all, I understand mechanical ventilation in three ways. One is transport of gas. Second is diffusion of gas. And third is distribution of gas. And as you know, the oxygen is a gas. It should float. But, sir, please mute your mic, sir. So what he has said that oxygen has to transport from the arterial blood. It has to be diffused. From the arterial blood, it has to go to the tissue. Tissue, there is oxidative phosphorylation. There is production of carbon dioxide and water, and oxygen is consumed. One of the most important things. So if oxygen has to flow to the tissue, it can go either ways. Either there should be some constant pressure gradient or concentration gradient. Concentration gradient occurs at the alveolar capillary membrane and also at the tissue level. Rest of the places, this is the pressure gradient. Second important thing, oxygen has to flow and it has to be distributed across the alveoli. That is also important. Third important thing is that what he has said, the oxygen is there in the alveoli, but it has to be carried by hemoglobin and it has to reach to the tissue by cardiac contractility. So if the patient is in shock, even there is oxygen in the alveoli, hemoglobin is low, oxygen will not reach the tissue. So I think these are the basic things he has taught. Another important thing to tell all of you, what is the purpose of a ventilator? Purpose of a ventilator is there to improve the oxygenation in the alveoli. Because whatever you are doing by a mechanical ventilator, it will work only at the alveolar level. It will increase the MAP. So beyond alveolar level, ventilator does not have got any role. So ventilator role is limited to the alveoli, to the lungs only. So beyond alveoli, there are certain things he has nicely described. One is hemoglobin, cardiac output, then oxygen extraction, etc. Third important thing is that when your patient is normally takes respiration, it is a negative pressure respiration. So during the time of inspiration, there is a decrease, there is increase in the venous return. So preload is more. But in mechanical ventilation, what we do, it is a positive pressure ventilation. So definitely there amount of some amount of hyperinflation of the lung. So that will decrease the venous return. So one of the most important thing that you should remember when you are ventilating a baby, try to keep the pressure as minimum as possible to optimize ventilation. Why it is important? Whatever ventilation you do, there will be some kind of hyperinflation of the lung that will decrease the venous return. Definitely that will decrease the cardiac output. So, and I think some of the questions are there. Let us take questions one by one. Why prone position improve oxygenation? Although due to gravity effect as well as in the upper part are less compliant. So see, in case of preterm newborn, because of the dome-shaped diaphragm, what happens in the upper part of the, when the baby is in erect position, in the upper part of the part, there is less volume distribution. In the lower part, in the more volume distribution. But if you keep the patient in prone position, there will be uniform distribution of the gases. That is why I was telling, gas has to flow to the alveoli, but it has to be distributed across the alveoli. So one important thing, when you keep the baby in prone position, especially the preterm infant, the distribution of the gas will be uniform. Second important thing is that when you keep the patient in prone position, there will increase contractility of the diaphragm. Diaphragm contractility increases. That way it helps. Third important thing is that suppose a baby is having PIE. If there is PIE, you keep the affected lung dependent. That will improve PIE. How it will improve PIE? When there is PIE, there is leakage in the interstitial space. So pleural pressure will be higher. When the pleural pressure is higher than the alveolar pressure or airway pressure, so whatever the dilated that capillaries or bronchioles are there, that will be collapsed. So one important message from his teaching is that gas has to transport, gas has to diffuse, but gas has to be uniformly distributed. And uniform distribution depends on the position of the lungs. That he has nicely listed. I think it answers your questions. Now you can unmute and you can ask question directly.
Yeah. Is there anything which you want to know? Because a few things I have not touched, mainly lung mechanics, because it will be covered in the next
In the
thing.
next lecture.
Uh,
Any new
and
question you can ask, you can easily ask. You can now unmute yourself and ask the question directly. Anyone? Or you can write in the chat box.
how prone position helps in PI? Can we know one more time, sir? Please, you have explained it. He is asking to elaborate it again.
PIE. So in PIE, what happens? There is leakage in the interstitial space. So there is interpleural pressure. There is more air in the pleural space. So if you can keep the lung in the prone position or in the affected lung dependent, what will happen? There will be more air that will go to the pleural space. So pleural pressure will be higher than the bronchial area, upper area pressure. When the pleural pressure will be higher, there will be more negative pressure. And the more negative pressure, that will lead to collapse of the alveoli or collapse of the distal after the alveoli or the bronchioles which were dilated. So in PI, what happens? It may be secular or it may be linear. So if these linear and secular areas are closed, definitely the better gas exchange will occur. Most of the volume that is lost in these spaces, that will not occur. That is the reason in PIE, if it is unilateral PIE, the dependent, if keep the lung and the dependent, that will help the baby. But if it is bilateral, then what we have to do? We have to do position change, one side up and one side down, like that.
Actually, yes, the sir has said that if you keep one lung down, the dependent portion of the alveoli will collapse, will become small and collapse, and it will not take part in gas exchange. So it will, after collapse, the PI will automatically resolve. It will also close. So it will help in early resolution of PI.
Yeah.
Thank you, sir.
Any more
Anything
questions?
else?
Just one thing. Remember two things. Gas has to transport, gas has to diffuse, and gas has to be distributed, and oxygen has to be carried. And this ventilator actually does inspiration. Expiration part is patience. What another example here said, the diffusion of the gas. Diffusion of the gas by fixed principle, it depends on diffusion coefficient of the gas, area available for the gas exchange, concentration gradient across the membrane, and inversely proportional to the length of the gas transport pathway. So if the alveolar are collapsed, there will be less available space for the gas exchange. That's why if you can inflate the alveoli, it will recruit the alveoli. The more and more surfaces will take part in ventilation. That is why I personally told him the gas has to transport and has to be distributed. So when you give CPAP, what happens? It recruits more and more alveoli. When more and more alveoli are recruited, more and more oxygen will be flowing to the spare alveoli. So the better will be gas exchange, the better will be CO2 exchange. So any more question, you can write in the chat box. Or you can adjust. Another important thing, as I told you earlier, what ventilator does, ventilator is limited up to the alveolar level. Beyond alveolar level, once gas is exchanged, oxygen is diffused to the pulmonary capillaries. Mechanical ventilator does not have any role to play. Rather, mechanical ventilator, if you give more pressure, there will be hyperventilation of the lung and that will decrease the venous rate. So beyond alveolar level, it depends on the hemoglobin content or content of the arterial valve, that will depend on the hemoglobin and also cardiac contractility. So if a baby is having good lung, but baby is having shock, no contractility, then also it will not reach to the tissue. Or baby has got a good lung, good contractility, but hemoglobin level is low. So then also oxygen will not also reach to the tissue. So if there is low oxygen or low saturation, what are the areas you can either, if you keep the patient on mechanical ventilator, we have to increase on the MAP, mean airway pressure. That is area under the curve. What Rameshwar was saying. If we increase the PWP, because we know the I ratio, expiratory time is more than the inspiratory time. So maximum time of the time in a one respiratory cycle, you will have more area under the curve. So oxygenation will improve. So if you want to increase the MAP, either you can increase the PIP or increase the PWP, or there is a rise time. So what happens if you want to actually improve oxygenation, either increase the MAP or increase the FiO2, or for transport of the gas, either you can transport hemoglobin or you can increase the cardiac contractility. So whenever a baby is desaturating, do not think by increasing the pressure, you are improving the oxygenation. You can, by increasing the pressure, you can transport gas from the alveoli to the blood. But if there is no hemoglobin, so when you are ventilating a baby, you have to consider everything. You have to see the lungs, you have to see the ventilator parameter, you have to see the alveolar capillary membrane, you have to see the hemoglobin, you have to see the cardiac output, cardiac contractility, etc. I think these are the things we wanted to make you understand. If you have got any doubt, you can ask. Or otherwise, we
Yeah.
can close.
I think they can
Fine.
also put their queries in the WhatsApp group, and our
WhatsApp group.
experts will answer according to convenience.
Yes. So,
Actually,
Okay, sir.
what we do when we are managing a patient is that we are targeting oxygen delivery. Oxygen delivery depends on two things: cardiac output and oxygen content. You manage cardiac output by inotropes or other supportive measures, and oxygen content is again depends on partial pressure of oxygen and hemoglobin. Now, but for hemoglobin, you transfuse the baby, and for partial pressure of oxygen, you use the ventilator, and where you use either MAP or FiO2, or you see pulmonary arterial pressure is normal or not, pulmonary perfusion is not. And for improving oxygenation, first thing you have to do is to improve ventilation perfusion matching, because this is actually the most common cause of hypoxemia. Apart from diffusion, diffusion limitation is less common, and it usually happens when there is pulmonary edema, and there is and decreased ventilation perfusion mismatch also will cause total surface area to reduce. So you first is oxygenation, then hemoglobin. So when you see the formula, you will get everything. There is everything on which we target during our clinical management of the baby.
Thank you, Rameshwar. I think it was a wonderful discussion, and there were some questions also. So I think if the participants have got any questions or queries, you can ask in the WhatsApp group that we have created, and our faculties will be happy to answer. I think if there is no question, we can actually wind up today. Thank you very much. Thank you all the participants.
Thank you all the participants. Thank you our speaker today, Speaker Dr. Prasad, for the wonderful in-depth discussion regarding the topic. So I think the participants have learned lot of things. Next online session will be on 20th August again at 9 p.m. and some faculty will come out with the topic. Thank you.
Thank you very much.
Thank you.
Thank you. Good night. Good night.
Thank you.
Thank you, sir.